I think it's the end of my presentation, but I can start with this one. The end of life is a really not supposed to be a human experience only. We have to combine all our experience. And this is my really small talk about. I would like first thank you for inviting me to participate in this conversation today. And I would like to speak what is the role of palliative care in the treatment of cholangiocarcinoma. Probably did the same mistake as you are. Oh, okay, so simple. I'm from Orange Regional Medical Center. Our main hospital is located about 60 miles from New York City. This is a geographical region that my hospital group is covering. As a palliative care physician, I really covering two main topics. One, I manage complex symptoms in a patient with a life-limiting disease. Second, I facilitate conversation about the patient's goals of care. All of my patients have life-limiting illnesses. And in managing their symptoms, I attempt a wide range of issues, dealing with skin dryness, managing constipation, elevating side effects of medication from aggressive treatment. I'm also hospital pain management specialist. And in my second role, I'm advocate for patients' goals of care. I explain to patients the likely course of disease will be for them. I ask them to consider the amount of time that they have to live, amount of time that they would like to endorse maybe suffering or maybe not. And I urge them to do decisions about their goals of care. My team helps patients to come to terms with their diagnosis and to find meaning in whatever time they have left. We not focus only on the medical aspects of care. My palliative team provides counseling, community support, and spiritual guidance to our patient. Our inpatient care hospital is a center of the system. However, it's key to note that patients coming to our hospital from different places. Yes, it could be from ambulatory clinic, sometimes patients coming from nursing home, from group home, and therefore, we really implementing tool that very popular in our state, New York State. It's a name, Electronic Medical Order for Life-Sustaining Treatment. This tool is incorporated in our medical record, electronic medical record, so that every medical personnel can be aware of what is the patient's preference and goals of care. What is crucial for patients, how we have to approach in a treatment. We use e-MOLST as a tool to initiate and continue tough conversation about how patient wishes his or her care to proceed, and ultimately where and how the patient prefer to die. As a palliative care physician, I not only encourage but demand this conversation because it leads to better patient's care. And it's important, believe me, not only for medical practitioners. It's important for all community. This includes spiritual leaders and the families of our patients. In our community, sick patient does not have to choose solely between aggressive treatment or only comfort care. This is a wide spectrum of treatment that patient can decide on. And before me, 3 different specialists actually offered different modalities. Patient has to choose, and we will help to patient, their caregivers, to their family to choose what is the most important. I see many patients, again, with various life-limiting illnesses. Various cancer is common in my practice. It's true, cholangiocarcinoma is really rare. And in practice, I see probably from 3 to 6 cases in a year. And I would like to present to you recent case. It is 89 years old female. She's coming to us with a known congestive heart failure, atrial fibrillation, hypertension, chronic obstructive pulmonary disease. She known to have diabetes mellitus. And actually for 5 last years, she knew that she has some liver nodules, but she never wanted to investigate why. She, for last year, lost 30 pounds. To us, she's coming because she's really have air hunger. She has severe dyspnea. Immediately in emergency room, we doing images, including CT of her lungs, and we see huge fluid collection. In emergency room, we placing tube, removing fluids, patient have relief. But at this moment, she realized that something really wrong going on, and she agreed to proceed with a biopsy of her nodules. And results is showing that she has cholangiocarcinoma and she has hepatocellular carcinoma. Family gathering around our patient. We definitely involving different specialists and oncologists immediately offering aggressive chemotherapy for this patient. She doesn't want to speak about her disease. She doesn't want to speak what is the approach. Family stepping in and quite aggressively wants that we leave our patients alone. Again, my approach at this life-limiting illness to offer palliative care to patients as soon as possible. Palliative care is often considered for later than it should, when a patient is close to the end of their life. And this paradigm is wrong. Overwhelming research shows that patients benefit greatly when a patient receives palliative care early in their life. If you're looking on this slide, this is an old model for patients with a life-limiting illness. Palliative care, and this model was consulted only in advanced stages. However, now we're looking for new model, and you can see when therapies to modify disease dominate patients' care, palliative care has a really small role. But eventually, we're introducing more and more palliative care, and we're using conversation about goals of care from the beginning. And it's drastically heightens the impact of palliative care, and patient more prepared to struggle with anything what patient is facing, and even the death. Unfortunately, again, in my case, cholangiocarcinoma, it wasn't. Palliative team was called, but was called by hospitalists. We help to our multidisciplinary team to manage patient nausea, fatigue, pain. Patient listen attentively to options and prognosis that we discuss with her. However, patient wasn't able to express her personal wishes because the conversation was dominated at this point by other family members. And family members, again, appointed, they do not want palliative care to be part of participation. Patient was discharged, and unfortunately, during this stay, she deconditioned. She was living alone before coming to us, but at point of discharge, she was stable, but she was not able to walk. Actually, it was very difficult to turn in a bed. She has tubes we were speaking about that patients sometimes coming to surgeon with multiple tubes. At this point, we have tubes in her lungs, we have tubes in her abdomen, we have multiple internal lines. And decision was made by, again, families that patient doesn't want to go to try any life-prolonging treatment. They would like to concentrate only on a comfort care, and patient and family did not discuss what it will be, what to expect. I know that patient will come back and forth to hospital. Nursing home will will try to support patient, but ultimately her health will decline, and if we will not readdress her status code, she could be resuscitated in a case of cardiac arrest, she could be intubated, and she could be tremendously suffering. But I still would like to highlight that we did have conversation. We pointed what to expect. We managed her symptoms. Yes, we didn't have consent interdisciplinary, and it seems really strongly not pointed. But having a conversation, starting with this was really, really good point for our patient. In my table, I'm showing, I will not go step by step, but I'm showing positive and negative of our intervention. If you're looking on this graph, I would like really concentrate on a very famous trajectory of cancer disease. Cholangiocarcinoma going on the same way. It will be crises for these patients. We will successfully treat them, but every time she will be declined, and it could be quite very drastic change at the end. Again, I would like to highlight that I always will be supporting my patient. I always will be supporting family of my patient. And for me, it's very important what patient wants by herself, where she wants to be, how she wants that we support her. And as I started my conversation, I would like again to underline the end of life is a human experience instead of primarily medical one. I was really enlightened by a speech that Lisa gave to us. It was so important for her, interventions of many specialists, but her personal experience, her retail therapy, her music therapy, her children, really, really, I do believe, change all care. And I really want that we as a palliative care team will be supporting our patients, their caregivers, and will be working together with all specialists. Thank you very much for having me.